Okay, this is my last topic. I mentioned in terms of our consults, Barrett's, polyps, and then colitis, IBD in particular, subtyping IBD, dysplasia in IBD. These are pretty common consults. You guys all see these biopsies. So I'm going to give you sort of what I think are the nuts and bolts of this topic and a couple of things that I'm going to focus on. So we see an awful lot of this, Okay, this is the quiz. Take a look at this colectomy specimen. Anybody want to give a diagnosis? This is not a trick question, I swear. I heard Crohn's. UC. Okay, well, so if you look at this, you can't quite tell down here, but this looks diseased. It looks like continuous disease all the way around. Pretty abrupt stop right there, and this all pretty much looks normal. Would you, for the most part, agree with that? Okay, so when we took sections from here and here and here and here and all this grossly abnormal areas, it was a chronic active colitis, which was diffuse. All the sections were involved. This is interesting because when you take sections from around this junction of normal and abnormal, you get patchiness. You get some areas that look normal and some areas that look abnormal. That's expected at the junction of disease, endoscopically or grossly abnormal disease with normal looking colon. You can get some patchiness. That doesn't mean you necessarily have to change your diagnosis to Crohn's disease. And then all the sections from here were completely normal. So this was a case of UC. When you put together the gross, put together the histologic features, we thought this was classic ulcerative colitis. Honestly, this seems to be the exception, not the rule. In terms of how straightforward it is, the longer I've done this, the more I think this is not as easy as most of us were taught in our medical school and in residency. I think it can be really difficult to separate Crohn's from UC, even when you have a resection specimen. I'm going to be focusing on biopsies and sort of telling us what our limitations are. So, do you get requisitions that say UC versus Crohn's biopsies, and they want you to try to tell the difference? And the question is, well, why do they even care? Well, I mean, there are some differences in terms of the biologics that are more effective in UC versus Crohn's, and vice versa. And I'm no expert in that. That's not my job. But actually, one of the main reasons they want us to help them figure out whether it's Crohn's or UC is because if the patient with UC really needs a resection at some point, either for uncontrollable disease or maybe for dysplasia, the best thing that they can have is what's called an ileal pouch anal anastomotic procedure. Is everybody somewhat familiar with that? I mean, the name kind of says it all, but basically what they do is they take the terminal ileum and they make a pouch out of it, and then they do an anastomosis. It's actually not an anal anastomosis. They actually leave a little bit of rectal mucosa, which I'll talk about a little bit later, to make that, and it makes the anastomosis a lot easier. So basically it's a continence restoring procedure, so the patient doesn't have to have a bag. So a continence restoring operation using the ileum to create a reservoir, and this is a general statement. It is generally not the ideal surgery in a patient with known Crohn's disease. Now, that's not an entirely true statement in that if you purposefully or accidentally put in a pouch in a patient with Crohn's, a lot of those patients do just fine. But statistically speaking, a patient with Crohn's is more likely to have issues with a pouch than a patient with ulcerative colitis. Okay, and in particular, Crohn's patients who have really bad ileal disease and anal disease are the ones that tend not to do well with a pouch. Aside from that, a lot of Crohn's patients actually do well with a pouch. But generally, that's why they want to know whether it's Crohn's or UC, because if there ever comes to an operation, or this is one of the reasons they want this, if it ever comes to an operation, they generally don't want to put a pouch into somebody with known Crohn's disease. As my former boss once said, this is a direct quote, "There is nothing like a pouch to bring out the Crohn's in someone." Okay, so if you think about that statement, what that means is, and this does happen, they can think a patient has ulcerative colitis sometimes for years, and eventually that patient needs a resection, and they put in a pouch, and pretty soon after they put in the pouch, things go bad, and then they figure out retrospectively the patient had Crohn's all along. And it wasn't until you put in the pouch that this became apparent. Okay, so that's kind of what happens sometimes. So when you put a pouch in the wrong patient with Crohn's, you can get this vicious cycle of things that occur. The pouch just never works, or you get a fistula tract, and then you get an abscess in the pelvis, and then you get sepsis in the pelvis, and then they have to do a resection, and this leads to short bowel syndrome, and sometimes a small bowel transplant. I mean, this is a bad series of events. If you put a pouch in the wrong patient, these are the kinds of things that can happen.